so up next, we're going to hear about Stevens-Johnson syndrome and implementation of HLA testing from Sony to Tasia. I think this is going to be really great because we just heard about how important this is for us to test. Now she's going to talk to us a bit about how hard it is to implement. Right? Yes. Okay.
Yeah, I wish I had all the answers, but I don't. I can just offer my thoughts. So thank you so much to Kelly and the organizers for inviting me to share my thoughts on implementation. My role at Penn is really focused on implementation as the director of pharmacogenetics, and I've really come to value implementation science. This is new to me, and it was valuable to us as we recently implemented another drug gene pair, DPYD, for chemotherapy-induced toxicity, which is also a life-threatening condition. So I think there's a lot of parallels, and I found the framework approach very useful in understanding the points of friction that we have when we're trying to implement things and then trying to develop strategies to overcome those points of friction. I'm not sure where the pointer went.
I walked off with it too, so.
It's okay. No problems. And so these are some of the acronyms I'll be using throughout my talk today. So as Dr. Manolial has already outlined for us, Stevens-Johnson syndrome and TEN is a very severe, life-threatening, immunologically mediated cutaneous adverse drug reaction with a high mortality and morbidity rate. And medications are implicated in 8 out of 10 cases of Stevens-Johnson syndrome, such as allopurinol and several anti-epileptic medications. And pre-screening with HLA markers can prevent SJS10 and other subcutaneous adverse reactions, but testing is not universally performed except for the case of HLA-B and abacavir. And what we want to answer is why this is not being done. And I think using an implementation science framework over the next 20 minutes, we can outline some of the reasons why. So what is implementation science? It's really the study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine clinical practice. You may have heard the statistics that it takes 17 to 20 years to get a research finding into clinical care and incorporated clinical care, which is really abysmal. And 14% of the research we do doesn't actually reach the intended target. So how can we shorten this process? And the field of implementation science is valuable in coming up with frameworks and theories and outcome measures and strategies that we can leverage in the field of pharmacogenomics and genomic medicine to make this a quicker time frame. But it's really more than just evaluating efficacy and effectiveness. There are so many factors in our environment that really impact if our implementation is going to be successful. So if we start in the orange box at the outer setting, these are things like guidelines that come from organizations, reimbursement decisions that are outside of our control, and then we move into the inner setting. This is the climate or the culture at our own institution. Is there resources? Are there supports for implementation? Are our leadership members engaged in this process? And then we have the individuals themselves, most importantly the patients, but also clinicians, researchers, and the staff that make this healthcare organization run. And they each have their own beliefs about pharmacogenetics and their own biases that they're coming to the table with. And we can't ignore these. We have to address these biases and develop strategies to overcome them. And we can discuss how that might happen. And then the yellow box is the intervention itself. So this is the HLA test. What is the evidence strength and quality about the HLA test that is important? How complex is it to do in a real world setting, and the cost of the testing? And then lastly, we have the process of implementation. It starts with the planning of how to do this, and it ends with evaluation. But it doesn't really stop there. Really, it's a cyclical process that has to be constantly measured, modified, and tweaked. So I mentioned I'm going to be applying this science framework and walking you through this for HLA testing. So I'll quickly describe some of the evidence behind HLA for several drugs linking to Stevens-Johnson, and Dr. Manolio has already gone over this. But then I'll spend some time identifying some of the practice gaps, like where are the gaps currently and why we're not doing this. I'll review some barriers and facilitators to implementation, how we select implementation strategies, and then systems to monitor, evaluate, and sustain this practice. So with the evidence, we've already discussed this. This is kind of the poster child for HLA testing. This was a randomized controlled trial conducted in almost 2,000 patients, showing the benefits of screening for HLA 5701 prior to prescribing abacavir. And you can see that in the PGX guided arm, there was 0 cases of immunologically confirmed HSR and a decrease of clinically diagnosed HSR. So this has been updated by the FDA, put in the package label, and it's mandated to be testing required before prescribing this medication. So with HLA-B in 1502, this was a study done in Taiwan, looking at screening over close to 5,000 patients, and those that were positive did not take carbamazepine. They were switched to an alternative medication, and you can see there were 0 cases of SJS/TEN in this, using this strategy, but it did not prevent all cutaneous adverse events, but we know that this particular marker, for example, is not associated with DRESS, which is another cutaneous adverse reaction that occurs, but it did prevent SJS itself. This is a study looking at HLA-B 5801 for allopurinol in Taiwan, and they employed a similar strategy where those that were positive did not take allopurinol, and they were prescribed other medications, and again, there were 0 cases of SJS using this approach. So what is the guidance that we have to implement HLA testing? This is just a review of all the HLA markers, and you can see that the FDA, as Dr. Manolio has already mentioned, there was boxed warnings for abacavir and also carbamazepine, which states that genetically high-risk populations, such as those with Asian ancestry, should be screened. But I'll just point out that HLA A3101 is not mentioned anywhere in the label for carbamazepine, so that's something that needs to be addressed. And then for the other drugs like allopurinol, phenytoin oxcarbamazepine, it's considered to be optional. So the testing is recommended, but it's not required. We also have guidance, and we can see that CPIC has guidelines for all of these drug-gene pairs at the level A evidence, and they provide nice recommendations on how to look for alternative medications in these cases in patients who carry these variants. And we also have guidance from some disease groups. So for Infectious Disease Society of America also recommends HLA testing for abacavir, and we have guidelines from the American Society of Rheumatology for gout that says that populations such as those with Asian ancestry and Blacks should be tested before prescribing allopurinol. So we have evidence that it works, that it prevents SJS, and it's beneficial. So next I'll talk about the evidence gaps. So how do we know that there's a gap in evidence? Well, we know that cases of SJS/TEN continue to occur. This is data from the FDA Adverse Reporting System database showing that there are continuing cases of SJS and TEN that occur with carbamazepine and oxcarbamazepine. While this, there's a lot of limitations to this database because of the voluntary nature of reporting to the FDA, but it still is a good signal for us to know that there's still a problem and these things are still happening. This is a different analysis of the same database, looking at all anti-epileptic medications, and this gets to the comment earlier about other anti-epileptic drugs, and I've highlighted the ones for phenytoin and carbamazepine, oxcarbamazepine, but you can see that there are other medications like lamotrigine. They're also highly associated with SJS/TEN, and anti-epileptics as a drug class itself was more significantly associated with this syndrome compared to any other drug class in the database. So that means that we need more research to be done to see what other markers are associated with SJS for these other medications because they're not linked with the particular variants that we are knowledgeable about. So also, there's a practice gap in that we know that testing is not happening clinically. So this was a study done in a large biobank from the Partners Healthcare System in Massachusetts, where they had 36,000 patients with pharmacogenetic test results. 6% had HLA-A 3101, 9% had HLA-B 1502. 92 patients went on to receive a prescription for carbamazepine or oxcarbazepine, and 4% experienced a rash that warranted drug discontinuation. And you'll see that only one of these individuals were of Asian ancestry, which means that the rest of them, went on to develop a rash that could have been prevented, but they were not going to be eligible for testing. And I'll just point out this is a research study, so none of these results were returned in the EHR or to patients to guide their therapies. Another study comes from the Johns Hopkins healthcare system, in which they reviewed prescriptions for carbamazepine and oxcarbazepine. And they had 302 prescriptions where the race was coded as Asian, other, or unknown. And they did further chart review, and they confirmed that there were 27 treatment-naive patients with Asian ancestry. Only one of these received HLA testing before prescribing these medications. So we do have a practice gap. We are not testing patients before prescribing medications. And the other gap is that the test itself is not perfect. We know that not all HLA, all the alleles are associated with multiple phenotypes of cutaneous reactions. So if a patient is positive for 1502, and we won't give them carbamazepine, but that is not going to predict their risk for DRESS or other cutaneous adverse reactions. And so there are others. So it might give you a false sense of security. So if you test somebody and they're negative, they can still have a different reaction because the other alleles are associated with those cutaneous reactions. So the test itself is not perfect. And just continuing with that theme, the test has a very low positive predictive value, which means that if you test positive, there's no guarantee that you're going to develop one of these syndromes. So you can see that this ranges from 1 to 2% for some of these other medications besides abacavir. So there's no guarantee that you're going to go on and develop Stevens-Johnson syndrome, even if you are testing positive. And that means that the number needed to treat is in the thousands, even in countries such as Asia, where the incidence of these alleles are much higher. So there have been several cost-effectiveness studies done for HLA testing, and the studies are mixed. This is a review that was done by Jay Patel's group, looking at all pharmacogenetic tests with CPIC guidelines, and I just picked out the ones for HLA, and you can see that most of the studies show either a cost savings or cost effectiveness, but there are a fair number of studies that show that it's not cost effective. And this is really predicated on the frequency of the variants in the population that you're studying and the willingness to pay threshold, which varies depending on the healthcare system and who the payer is. There's also a confusion about what test to order, and this is an example of what I type in our own EHR at Penn for HLA-B, and you can see there's a plethora of choices, and having spoken to rheumatologists and primary care physicians, and even our HLA lab director, it's not clear to people which test to order when they're trying to order a particular HLA test. So when people want to order it, we have to make it easy for them. We have to tell them, we have to streamline this process and clean up this menu of tests to say, well, this is the right test you should be doing. We really have to make it easy for them. So we've talked about the practice gaps, and so I'll next talk about some of the barriers and facilitators to implementation, and I'll go back to the CFIR framework. We're looking at the different domains in our environment, outer, inner, individuals, interventions, and process. And I'm not going to go through all of these, but I really want to highlight some. For example, we don't want to employ an implementation that it widens the equity gap. We have to be mindful of which variants are present in our patient population, and does our test incorporate the variants that are important for all populations and not just some populations. And the other point I'll point out is the population admixture. Now, this is only going to increase over time. My kids are of mixed ancestry, and looking at them, you can never tell they have Indian heritage, So I think it's going to be harder and harder for them, for clinicians to know who's Asian and who's not, to be able to offer this. And we really want to get away from race-based medicine and have the test available for everyone. But on the facilitator side, I think what's really going to be really important is collaboration across institutions, across countries. And I think one example of this collaboration is implementation working groups that's, for example, formed within the PGRN. And it's already been mentioned, but multi-gene panels, I think, is going to be a big facilitator for making sure we have this data in the EHR when we're going to be prescribing medications going forward. And as the cost of testing goes down, it just makes sense, as already been mentioned, to do a panel instead of a single gene at a time. And I've spoken to a couple of rheumatologists, and they were like, yeah, I'd be open to a panel if it costs the same amount of money. I think that they just don't know that this exists and how to do it efficiently. So the field of implementation science has actually has a catalog of 73 different strategies that you can choose from, and they kind of fall into these 6 different buckets. So, and selecting strategies really depends on the barriers at your institution, and it has to be multi-level. Like, you have to address it from each domain, right? You can't just expect to implement one of these strategies and hope it works. Because the problem of implementation of pharmacogenetics is so complex, we have to choose strategies from each of these domains and address each of the barriers. So this is just an example of me as an implementer trying to go through each of these factors, addressing each of these domains, and maybe coming up with a potential strategy. I'm not saying this is the answer, but this is how we can start to think about how do we get this to work in clinical practice. For example, in the outer setting, we have guidelines from the Rheumatology Association and CPIC guidelines, but I can tell you at Penn, none of my primary care providers or even rheumatologists know about CPIC at all. And while the rheumatologists are aware of the rheumatology guidelines, this information is not being disseminated to primary care. So how do we have strategies for disseminating information to other providers? With the inner setting, as I already showed, it's really unclear which test to order and how to order it. And so can we do something to streamline the testing options? When we look at the individuals, I think clinicians lack the awareness that testing needs to be done, and maybe we need to provide education in a readily accessible format. As already been mentioned, UpToDate is very popular with primary care physicians, and what information is there in UpToDate to guide them to order testing? What about the patients themselves? We know that they're not being offered testing, and so can we remind providers to order testing for these patients by creating some sort of alert in the EHR. And EHR alerts, I know, are really a sore spot for some providers because we have too many, but that by themselves, they're not going to work. But if we employ it with a menu of other strategies, perhaps it will work. And so as far as the process, I know clinicians lack time in their clinics. They're very busy, and there's no time for pre-test counseling about the test itself, what it means for them, what it means for their family members, what are the alternative therapies, what are the costs of those alternative therapies. So I think this is where we can really engage pharmacogenetic pharmacists to assist with this process. And I think we really have to engage the end users, right? So what do the physicians think? What do patients think? And there's not enough empirical evidence in our space to design strategies based on empirical evidence. We're just kind of picking strategies based on what we think might work, but really there's no empirical evidence. So this is a study that was done in the UK using discrete choice experiments with 92 neurologists and 92 patients, giving them various patient case scenarios and asking them, would they be willing to order the test for this patient who might have, if this test had a positive predictive value of 2% and negative predictive value of 70%, would you test before prescribing a medication? So if you do this iteratively over and over again, you can get some kind of importance score of what is that threshold of where a provider might order a test. And similarly with patients, you give them scenarios and the trade-offs between efficacy and side effects, and you come up with a threshold based on data that this is where patients would have an acceptability of doing a pharmacogenetic test. And so this experiment showed that what was important to clinicians was the cost of the test, the positive predictive value of the test, and was it included on the formulary in the UK. For patients, they were actually willing to accept a reduction in seizure remissions if it would meant an offset in adverse events. So I think it's really important that we ask our patients what they want and not take a paternalistic view of medicine. And I've really leaned, I think qualitative methods are another important way in what we can ascertain what's important to our end users. This is a qualitative study done in Asia as they were trying to implement HLA 5801 for allopurinol. And this is a representative quote from a physician who says, "I think it depends on my patients. If they're the types that are more affluent and good health literacy and they can afford febuxostat in the future, I would be more willing to offer them the HLA test. But if my patient is from a poor socioeconomic group and they keep suffering from gout and they need to be on medication, I think I would just counsel them to watch out for side effects and come back if anything happens." So this just kind of gets into the frame of mind of what providers are thinking, and these are the barriers that we're up against. So how do we educate and overcome this? If we look at what the patient said in this study, this patient said, if I see the value of it, then I will do it. The investment is for your health, and so I will do it. If I cannot claim this, then I'll figure out another pay to pay for it for myself. If I see benefit and there's an appeal, I'll just find the money to afford it. So I think if we educate the patients with the knowledge about testing and the alternatives and put this in the framework of a shared decision making, I think patients would be willing to undergo testing. Lastly, I just want to touch on evaluation and sustainment. I'm not going to have enough time to go into all of this, but I think I really like this framework by Proctor because it looks at implementation outcomes as the intermediate point between the service and patient outcomes that we so desperately want to improve, right? So how do these implementation practices and strategy influence these outcomes? And they really go through these intermediate outcomes. So acceptability, appropriateness, feasibility. And these are important because they really get at the process of implementation, and they are outcomes that can be measured in the short term, and you don't have to do an effectiveness trial and find out at the end that your intervention didn't really work, and then you're like, well, why didn't it work? But if you had measured some of these implementation outcomes along the way, then you can kind of tease out it's because, 40% of my results were not back before the medication was prescribed. So is that a modifying factor that we have to work on and tweak that process of how do we get the results back before prescriptions are ordered? So they can really help in also monitoring the success of implementation. So what are our benchmarks? Like how do we define success, and how can we modify the process to achieve those benchmarks? So in conclusion, I think we have evidence for HLA testing that it works. It improves, it prevents death and serious cases of SJS and decreased healthcare costs, depending on the scenario. But there's still some, evidence to practice gaps that we need to work on. These guidelines that we have are not widely implemented. Most people don't know about CPIC. We have continuing cases of Stevens-Johnson syndrome that continue to occur. I think our optimal strategies for screening patients have not been developed and rigorously tested. The test characteristics of themselves are not optimal, and there's lack of awareness. So I've reviewed some barriers and facilitators to implementation and some strategies that we can go move forward. And I think I just want to point out that we should really be paying particular attention to issues of equity, because there's lots of data in the genetics testing literature outside of pharmacogenetics that says that minoritized populations are not offered genetic testing. So we really have to be mindful of this. So I think in future directions, we need more studies in diverse patient populations and more rigorous evaluation of strategies and contextual modifiers of successful implementation. Collaborations to increase power and to evaluate our strategies in multiple clinic settings. Does it work as well in a community setting as an academic healthcare setting? And then we have to include other risk factors. For example, renal function. How does renal function modify the risk of SJS and someone getting allopurinol? And also we need to bolster our pharmacovigilance activities and methods to monitor for adverse events, and more research to identify additional genetic susceptibility loci. So lastly, I just want to acknowledge my team at Penn. I have an amazing team of people in the PGX program. Just want to call out Glenda Hofficker and Marie Kayebyeb, who do all the hard work of making sure our program runs smoothly, and my colleagues and collaborators in the Penn Implementation Science Institute, who really have helped me think through this process, and happy to take questions.
Great presentation, Sony. Thank you. I was wondering if we know how the rheumatology group was convinced to put pharmacogenetics in their guidelines, and if we can replicate that in other clinician association guidelines.
I do not, but that's a good question. I'm meeting with them in August, and so I will ask them that. Okay, thanks.